see markedly reduced flow in the MCA once the catheter is in situ. This company also offers some transradial access equipment so that these procedures can be done transradially. In terms of stent retrievers, there is a new company called Triticum, and this is a novel polymer-based stent retriever, which has some microsurface technology which allows engagement with the clot's microstructure. It's an over-the-wire design, and it's actually unlike any other stent retriever that I've ever seen. So here you can see that actually this is the distal end, and this is the proximal end, and it has these sort of foot plates almost. And the idea is to track those up to the clot. And then when you start retracting, you can see that these sorts of end plates, these foot plates almost, these sort of flare open. And the idea is to interact with and drag the clot out as with other stent retrievers. So this is a very novel design, and it's the first polymer-based stent retriever to hit the market, to my knowledge. Inretio is another novel designed stent retriever. And this basically is a device where you, to my knowledge, have both control of the distal and the proximal end. It's sort of like a cage-like device almost. But there's no publications on this at the moment. Now, this is a novel, an interesting concept. So there's a company called Capto, which is a spin out from research being performed at the INSERM Institute in Paris. And this is a novel binding, actually, a coating that can be applied to stents that basically attracts and binds to neutrophil extracellular traps and the DNA that they sort of spew out in their formation. Now, because the nets and the free DNA are present in the clots, but not in healthy blood vessel, or on blood vessel walls, the coating actively binds only to the clots without adhering to the other sort of normal blood vessels and the vessel wall. And there's no change in the properties of the underlying device. The DAISY is another novel technology which is aimed at reducing microemboli, and just like with the Capto device, which has been shown to reduce some microemboli, this is a more structural way of doing it rather than coating, and it's essentially a bit like a sort of polymer filter that is passed through the clot distally. It can be expanded up, and then the MIVI aspiration device is taken to the proximal clot face to aspirate out the clot, with the DAISY catching any little microemboli to prevent further infarction seen distally. You have the NEVA net, which is designed to do something very similar. So this is a distal filter, a bit like a web, I suppose, at the end of a NEVA stent retriever. And again, benchside studies have shown that you see fewer distal emboli compared to both a solitaire, which is open-ended, and an embotrap stent retriever, which has a clot catcher distally. Currently, you've got a 5.5 by 37 millimeter device, which needs to pass through an 0.27-inch microcatheter, but soon a 4 by 30 millimeter device, which can pass through an 0.21 microcatheter, should be available. And my initial experience with this device, it has actually been very promising. The radial force is similar to a solitaire, and as you can see, you see markedly fewer distal emboli with the device. I'm looking forward to receiving the smaller device, and I think in combination with the Walrus and the larger aspiration catheters, we'll see very good results. Certainly, my experience with the normal NEVA has been fantastic. With regards to ICAD, there was a very nice and very interesting presentation recently given by Professor Nobuyuki Sakai with a device coming out of a company called TG Medical. The device itself is called the TG Dilator, and this is a novel stentplasty device. It is placed temporarily at the site of ICAD after acute ischemic stroke to cause controlled dilatation. So it's a stent-based dilatation rather than a balloon angioplasty-based dilatation. The initial results presented by Professor Sakai at the recent SIMI meeting showed 10 cases performed in Japan, all of which showed very promising results, no major complications, and the results will be published shortly. I believe that this offers a new and perhaps pivotal change in the way that we look at ICAD, because I believe stentplasty will represent the dawn of a new era in the treatment of ICAD, which will be both safer, faster, and far more controlled than the use of balloons. Particularly, I think using suboptimal cardiac and coronary balloons is probably not a good idea for our patients. Finally, from Spartan Medical, there's a device called the center wire, which is essentially a stent attached to a very long 350 centimeter wire. And this enables exchange maneuvers to be performed more safely. In their initial first-in-human study, there were no complications. And this might have advantages if, particularly in tortuous anatomy, for tracking up catheters into place to finally deploy stent retrievers or large bore aspiration catheters. So those are just some of the technologies that I'm aware of. Many of these will actually be presented by the developers or the companies themselves at Brain Conference, which I heartily invite you all to. It will be running from the 4th to the 6th of December in London with Professor Liebeskind and many other esteemed speakers from around the world presenting. So I hope to see you there. And if you can't join in person, please feel free to join online. And with that, I would like to thank you very much. And I hope you've enjoyed this and look forward to using many of these new technologies to the betterment of our patients.
Okay, good. But we can't see you. So I know it's late. Where are you, in Chicago?
Yeah, Chicago.
Okay. So, oh, we can see him? No, we won't demand video, but on screen. But Demetrius, thank you. Thank you for being patient. So you know what's been happening here locally in Los Angeles. We had logistic issues. We had to relocate. So we're back in the room. We're getting other people in, and we're herding people together. So we're going to have in a few minutes, when everybody comes back, probably about 10 minutes or so, what is known as a Jeffersonian debate. So what a Jeffersonian debate is at the time of Thomas Jefferson, it was congregations of people to get together, people that were actual thought leaders that had intelligent ideas, meaningful contributions to the field around a focused topic. And, you know, the general rules of a Jeffersonian debate and a Jeffersonian dinner are that you invite people to bring different perspectives. So one of the things that's very important is inclusivity, to have different perspectives, bring this together, and then to have an active debate about these points, and then perhaps to go around to hear from everybody that's involved. And here we're going to make it very communal, both virtually as well as in person, and action items. So, you know, obviously, you know, it goes without saying that our entire focus is on stroke. And, you know, it's enough of a topic. I mean, when we talk about TTST and collaterals, there's plenty of topics to talk about. But so many of the ideas that have come forth have to do with how do we move forward from 2023. We have a lot of new data. Some things that are confusing. What is the best strategy of moving forward? whether it's with thrombolysis, whether it's with adjunctive drugs, whether it's with thrombectomy, and some ideas. And the other part of it is sort of the methodology. So we have Pranitha here who's going to speak about in silico trials. Again, is this the best way of being most efficient? Why should we waste so many years of our lives? It's fun to see each other and get back together socially every few years. I think everybody would admit, especially in person rather than virtually. But we do this every few years, and the question is, how do we accelerate this so we can meet, and we will meet, very frequently over time. But how do we become more productive during the time interval? So we have fewer negative trials, and we're more like, I hate to say this, but more like our medical colleagues, more like the cardiologists, more like the vascular surgeons, the happy guys, so to speak, in terms of just moving on and not quibbling about the data. So, all right. So why don't we start this debate? Wait, no, I can't be the only one on the stage. So some of you have to volunteer. And by the way, if we need to, by the way, this is meant to be a TED red carpet, where you have the focal point, but you can sit. You don't have to sit on. Yeah, but so there is a circle, Jim, but there's it's a limited circle. So we want to be as inclusive as possible, not 4 seats. All right, so everybody can sit. If you want to sit on the edge of the stage. Yeah. Just sit around here. No, it's okay. Oh, Zurab is worried about the appearance of having alcohol in the picture. No, it's okay. It's okay. Yeah. So we have 4 seats. We have a fireplace. It's a modern fireplace. It's digital and green. And Pooja. We have plenty of room up here. So let's have a big circle. This is kind of like kindergarten. Nobu. Johan, come on. We want to be inclusive. Yeah, no, more people will come in. So I'm going to step out and rally the troops. But all right. So the theme here is, how do we capture? No. Yes, they are. Yes, you can't tell that virtually. It's a. All right. So you have a paranoid, the virtual crew. You have a paranoid local audience. They don't know who's out there. So whoever's willing to divulge who's there, speak up. But you should, behave appropriately, right, Peter? Always. Okay, all right. So I'm going to leave the microphone so I can rally more people, because there's a lot more people coming. I don't know where they went, but I'm going to bring them. And let's have an active discussion, based on stroke. All right, so we're gonna have an active discussion. Let me leave you with one mission. No, I'm stepping out for a second. I'll be back in a second. But the goal is to talk about, how do we move forward from here? All right, but in Jeffersonian practice, you let everybody speak, express their opinion equally, and then pass it around, and and people should summarize their thoughts concretely in terms of next steps. So stroke, and how do we advance therapy?
I have heard many things today and yesterday that were not surprising. I heard one thing, and I couldn't ask Jim about that on his presentation of mobile stroke units and the break-even value and 50 patients that would be needed, and especially quality adjusted life years and an ICER of $190,000. I was so surprised, because in Europe it's about 45,000 euros that is accepted. In UK it's about 40,000 pounds, which is about the same. So I was so surprised. So $190,000, is that widely accepted now?
Yeah, that's right. It's an American life versus a German life. I mean, you know, the fact is, that's Jeff Saver came up with that figure. Remember, the $50,000 figure came up with 20 years ago, right? We've been using that figure for a long time. Well, $50,000 20 or 30 years ago was, you know, well over $100,000 now. So I don't know if I buy the 190,000, but I think $50,000 is a very low, very tough threshold to meet for in terms of a quality adjusted life year, I think. So anyway, 190 is what, based on the gross domestic product, there's a calculation that you do and that you use to calculate, divide that by the number of people and life expectancy and stuff like that. And you come up with a figure for what 1 year of life economically, theoretically is worth in the country. So that's a figure. But having said that, 50 patients a year actually would bring you down to the $50,000 threshold. Yeah.
Okay, wait. But how do you translate this figure that is out there to something that your hospital CEO administration will buy as actual dollars?
Yeah, well, the hospital doesn't care about that because the hospital just having to pay for their dollars, but Medicare and, you know, we'll look at it and others and we'll say, well, you know, this is cost effective or not. But in reality, I don't think that figure means an awful lot. I do think at the end of the day, it's a matter of whether the hospital is going to lose money by getting reimbursed, but the reimbursement is tied to whether it's cost effective. So I thought you were going to ask me about something else, you know, like why I don't really care about giving TPA after 3 hours or not.
He couldn't sleep over the $190,000.
The 3 hour or 2 hours, 15 minutes limit would have been my next question, because why are you so adamant about RTPA is great, but it's not great after 3 hours, and the ECAS-3 trial sucks?
Wait. That's Ashu. That's Ashu. He is missing.
Yeah.
Hold on. That's Ashu. Okay, so yeah, when he gets in here, please text him. He's on.
Okay, then I got that wrong.
Hours.
So if everybody here thinks 4.5 hours, then that is nothing that we need to discuss at that Jeffersonian dinner.
In the race cat trial, in the race cat study, which showed that, you know, if there's a 37-minute extra time it takes to get to the comprehensive stroke center, you're better off going to the primary stroke center, or just as well off going to the primary stroke center. However, if the time from symptom onset to the time the patient could get TPA was more than, or to alert, from the time from onset to alert was more than 120 minutes, meaning the patient couldn't get treated within 2 hours, then it was much better to go to the comprehensive stroke center. In other words, getting TPA super quickly was not that important if the elapsed interval was more than 2 hours.
But that is sort of stepping. No, I have to answer that.
Peter,
And Ray, I have to answer that because that was not the trial. The ECAS-3 trial did not look at patients in the 4.5 hour time window, but randomized within 3 to 4.5 hours. So for that specific time window of 1.5 hours, the ECAS-3 trial showed, without any question, showed a significant benefit of fibrinolytic therapy. And whether that has been adopted or not by guidelines or by labels or whatever doesn't really matter. I think that question has been settled by ECAS.
well, in United
This is
States, it was-
non-controversial. I'm
yeah.
just gonna say, like, our guidelines say 4.5 hours. This is just an FDA thing. I don't think the USA thinks any differently than 4.5 hours. I don't think there's anything to debate here.
I just got a different perception today.
No. Peter, we're gonna bring the person for you to debate in just a second. But what Pooja and I is saying, that the moment ECAS 3 was not used to extend the label with FDA, the response from scientific community was scientific statement published in Stroke saying that we support 4.5-hour extension. And later on, it just went on to the guidelines. So that is not a point of contention. The contention is, I guess, around what Asher was saying about vis-a-vis thrombectomy, and what we do if there is a large vessel occlusion, particularly the further we go down the lines. So we will wait for Asher to join us. Meanwhile, let's discuss some other question, and we have wonderful people joining us at this wonderful kids by the fireplace evening. Yeah. No one's gonna read John Malkovich Christmas book unless unless David brought it. I don't think anyone knows what I'm talking about. All right. Next question, David. All right. So what came today is the most kind of boiling point, and you wanted to hear more about discussion, maybe from one of the speakers, or particularly the ones that are here.
TNK versus TPA.
All right, TNK versus TPA. What's so unsettled? TNK. All right.
What is your opinion, expert's
So
opinion?
as I pointed out this morning, I switched two of my systems to TNK, but there are big burning questions remain unsettled. There is no FDA approval for TNK for acute stroke. So you, as practicing clinicians, will be hanging on a thread of claiming, if there is a complication, that TNK that you gave off-label is based on the currently acceptable standard of care at your institution, which lags usually a couple of years behind of the whole thing. And I'm glad there are takers on that.
So if you look at litigation all around in stroke today, ischemic stroke, 70% of all patients who sue, 70% of all patients who sue doctors for acute treatment in ischemic stroke sue the physician for not giving TPA when the patient qualifies, not from giving it, right? So when you look at the risk to the physician, in my opinion, and I asked this question twice, I said, we have all these trials that show non-inferiority of TNK to TPA, with some parts saying that there is a suggestion to superiority and a safety profile that is largely similar in a setting where, you know, if we throw economics out, like was talked about earlier today, but more imperatively that you can inject the drug as a bolus injection and then you're done and you've provided therapy. What does it matter if it's not FDA approved? Because we have physician consensus that it's the right drug to give. I mean, if I was Genentech, I would just keep my mouth shut, stop sponsoring trials, and let the physicians go to town.
Not that easy. Hold on. I raised the legal issue. So the question that lawyers often ask in a preliminary phase is the decision of physician to give TNK is standard of care for your hospital or surrounding areas for that time of the complication. And as long as we are not completely switched to TNK, you're in a vulnerable position that someone in the community is going to say, he used off-label medication, we're all giving another medication.
Okay, I'm going to interrupt, because that's a very American view of the world, and America's only one country in the whole globe. In the rest of the world, we have moved on and used TNK because there is very convincing evidence. In New Zealand, we have shown over and over that it reduces door to needle time, reduces door to groin time, so it significantly reduces regional inequities. There's some evidence to show it's cheaper. It's actually not cheaper in New Zealand. There was some issues raised around using the fold cardiac dose instead of the stroke dose, but how many of your patients are exactly the weight of a 50 milligram vial of alteplase? I'd like to know that because none of my patients are. And actually we almost always use 1.5 vials of dose. So we waste dose all the time. So I think actually you stand on very firm ground with international evidence, international community, and it's just an American problem, really.
You know, it's because we live in a litigious environment. So
You do. I'm sorry, you do.
The point.
Let's pass the microphone around. And by the way, the people that are living on the edge of the circle, Nicole and others, come in. Kentaro, Naoki.
Just answering to that. It is not the point that was made was not about TNK versus RTPA, but the point that the majority of lawsuits in the US is made because of having not given fibrinolytic therapy when it should have been given. And in Germany, that is like zero. You don't get any lawsuits for complications of TPA. The only lawsuits that you get that TPA or an alternative is not being given when it should have been given. I think it is just a question of being correct unless clear superiority of TNK has been proven. There is no reason to deviate from established systems to give RTPA. Once superiority is proven, we can deviate from that even if legal approval or label has not been changed.
All right.
Okay,
Budget has a rebuttal. Okay.
Yes. So bottom line to me is the only reason we're debating this is twofold. One is that Genentech, at least in the United States, wants to be able to market TNK, and the only way they can do that is with FDA approval. That is a driving force in the United States. The second is, at least my understanding, and my California colleagues can correct me, but my understanding is that in California, there is a particular issue around using TNK if it's not FDA approved. Is that right, Dave? Yeah, there are potential issues. Just in California, it's not an issue. Like I'm in Ohio, we're using TNK and we've just moved on.
Well, I think we're caught in general.
It has to do with like label and Medicare, right? And CMS.
There's differences in terms of what we deal with in terms of guidelines versus FDA approvals in terms of what's being reimbursed. Those are each different. And I agree, Anna, it is an American problem that we struggle around. You know, a lot of places around the world, it's a lot more simple. We're a little bit more, legalistic, trying to obey by the rules in this country. And it becomes very confusing because there's a big difference between what guidelines say. We're a lot more stringent than Europeans, Peter. And what you're not necessarily allowed to do, but what you're going to get paid to do, and reimbursed to do. And payment drives practice.
Well, and I want to throw out one more thing, which is everyone keeps talking about how TNK is cheaper than TPA, but it's the same people making both. And as soon as TNK is approved, let's be honest, TNK is going to cost exactly what alteplase costs. So this is not about cost saving.
Thank you for repeating all my points from morning lecture. Zurab, last comment until we move to the next one.
Do we believe in evidence-based medicine? So thus far, there is no evidence that TPA is better than TNK. I think we should agree with this, right? I mean, all clinical trials show that they are equivalent. In addition to that, if you will take, or TNK is better. And in addition to that price, I mean, my hospital was convinced right away that when I showed them that it's 3,000 cheaper, right away. So anyway, at this point, what we have based on the clinical trial, one after one, that there is no evidence that TPA is better than TNK. So at this point, I think it's reasonable to switch to TNK.
All right. So that was Georgetown. That was Georgetown University perspective, which was great. Georgetown. Working, right? How about now? All right, excellent. Okay, we're back. So since we now close TNK TPA discussion, Peter had a question for Ashu.
You're in the hot seat.
Oh, yeah, I asked that before. You come up with a 2 hour and 15 minute NLVO time cutoff that TPA should be given, or TNK or whatever. I still think that that is
3.5 hours also.
it is an endpoint that is done from a calculation from trials that cannot just be lumped together. And it comes from trials that are from all over the world, that where the point estimates go into different directions. I just wonder how this statement can hold true when labels say something and guidelines say something completely different.
Yeah, I mean, I like, for me, the thought experiment that interests me a lot is that if you go back to, 1998, you had PROACT 2 and MELT, which showed that intraarterial, at the time, prourokinase or lytic was superior to standard of care at the time. But intraarterial kind of took the back seat because alteplase was approved by FDA and that became standard of care. So PROACT 2 and MELT kind of went by the wayside for a while. And then we had, to wait for IMS3 and then for the endovascular trials. But to me, let's kind of flip the order here for a second. Let's say endovascular therapy was a standard of care. And then along came a drug called alteplase. And you had to then basically show that alteplase, in addition to endovascular therapy, was going to yield some sort of benefit. Right?
I'm gonna hold hands.
Right. So if you look at the IRIS data in those lens, you would say, okay, like you've got a treatment that works very well, which is thrombectomy, and now you're adding on something, a drug, and is that drug going to yield some kind of benefit? Okay, so if you look at it from that lens, and if you look at the IRIS data, which I understand is a patient level meta-analysis from trials from China, Japan, and Europe, it doesn't matter what the margins they're defining as non-inferiority. We're just looking at when is there benefit of adding a lytic, and their data suggests that it's 2 hours and 15 minutes. So if you're looking at this purely from the lens of what's really beneficial here, forget the order in which the trials were done, because we're very molded to this idea that lytics came first. Lytics are the number or the treatment to beat. And I would say if you flip the order in which things happened, you would have a very different perspective on what the bar should be to showing benefit.
What about the fact that the original trials actually compared lytic versus intervention?
But they were done poorly.
Wait, guys. First of all, Ashu's dream almost happened. Do you know when PROACT was published? 95, 99. They were in development in exactly the same timeline.
And that's
Yeah.
exactly my point.
But following the MI, he is ready to launch, and I'm trying to get the fuse out of him because otherwise he's going to explode. So
I'd look at it a different way. Can I? So we heard today about von Willebrand's factor and a combination of prourokinase and TPA or TNK as alternate lytics. And the landscape to develop those very exciting potential new thrombolytic therapies are entering into a landscape where TPA and TNK are already approved. So the question is how you're going to test those drugs. And so at some point in time, and yet it has to be tested in patients that are candidates for thrombolysis, right? So at some point we have to figure out where is there equipoise where a person feels comfortable randomizing a patient that's from established treatment with TPA or TNK versus one of these investigation drugs.
But before we go
Let-
to that equipoise, let's address the history conundrum here. So, Peter.
One informational thing, PROACT 2 has been disputed whether it was positive for pro-UK or not, because there are reasonable data that show that the control arm artificially harmed the patients, meaning infusing heparin would cause a detrimental effect to the control group, thereby causing the significant difference in favor of pro-UK. That is often forgotten, number one. Number two, we are not living in the multiverse of DC comics where there are alternative histories where endovascular treatment was first and the Flash goes forth and back and kicks Superman in the ass. It's just we have our single universe and lytics were there first and endovascular therapy came afterward. And that is why we have to follow through, and fibrinolytic therapy, whether it be TPA or TNK, comes first and the rest comes on top of that. And I think that in the majority of all people that treat stroke is not going to be disputed. Pooja,
Well,
your
no,
opinion?
I mean, I would sort of add, we don't live in the multiverse universe, but we do live in reality, which is that these drugs cost a lot of money. And in the real world, at some point, there should be accountability for why we're doing what we do. If you look at synthesis, I know we talk about IMS3 and MR rescue, but in synthesis, people got randomized to IV thrombolysis versus IA thrombolysis, and there's no difference between the two groups. So I think that there is increasing data that for patients who are thrombectomy eligible, we have to ask the hard question, do all of those patients need thrombolysis prior to thrombectomy? We know for IC terminus occlusions, the efficacy of thrombolysis is marginal. I think that we do a lot of gymnastics to explain that tenecteplase with, in the case of timeless, may have some subpopulation that benefits. I think with the IRIS data, we're starting to see some inflection point temporally where there may not be much additional benefit of thrombolysis. And, to me, this is breaking the mold. And I understand that's hard to do, but just because the guidelines say X doesn't mean we have to do it. Just because we've been doing it the same way for 30 years doesn't mean we have to do it.
All right,
But,
And-
be careful
we need to stop
of
here.
what
Let's-
you're asking for,
let's
Ashu.
do-
But
let's do
because
short
if you're
comments.
going to be held accountable for outcomes, that also means outcomes after endovascular, and we're looking at an age where we now have large core trials. Who's going to set the standard for what is an acceptable outcome that you're held accountable when you're taking a patient with an aspects of 4 into the cath lab, right? So I hear what you're saying, but at the same time, if you're asking for outcomes measurement as the way to hold accountable what we can do, then we may actually be sealing off treatment to patients that could benefit because the majority are not.
Okay, so
No,
very
but
quick, very quickly, accountability. Do you believe in a concept no stroke left behind, or should we change our systems of care towards 15% that you can address right now with casters? That's the
No.
question.
And I'm talking
maybe
about
it's
I'm talking
20 or
about breaking the
30%.
mold, though. I'm talking about like right now we're so ingrained that if someone is in the ED with an IC terminus occlusion at a thrombectomy capable center with the IC terminus occlusion at 3 hours, we're so ingrained that person has to get lytics. And I'm just saying, is there any room to budge that mold?
But why are
So-
we
so
pushing, but
ju-
why are we pushing that so hard? We took the scenario where if at any situation endovascular therapy was supposed to win, it was the mothership. And we know the majority of patients are not showing up at the mothership. And we also know that the majority of patients actually don't have LVOs. And if we're doing our systems well,
we're starting thrombolytic therapy, intravenous thrombolytic therapy before we even know there's an LVO. The best places are getting the CT scan, shooting the IV thrombolysis, and then getting the CTA.
So,
Wait.
Andre,
Let me finish this thought real quick. So do you know why direct to MT versus IV to MT was never done in the United States? Because we could never find a morally acceptable situation where I, as a vascular neurologist, will withhold TPA, even in the scenario you described, Because what happens is, in ideal world, terminal AC occlusion at a thrombectomy center shows up, okay? When am I prepared to forgo TPA in favor of thrombectomy? When you and I together are looking at the CAT scan as it appears, we see hyperdense terminal ACA dot sign, and you say, I am ready. And I will not waste my time on CT perfusion or other things, and patient goes directly to the cath lab. This scenario is ethically and realistically impossible unless two
That's
of
every
us.
day. Every day when I'm on call, I'm the same guy.
No,
So I
you
see that's-
are maybe in an unreal world, being a stroke neurologist and in the vascular in one person. I, as a stroke neurologist, taking care of 100 emergency rooms in Alabama, was by myself for all these patients, and I had to chase you guys out of golf courses, boats, in flexibility of looking at, oh, too many changes, I'm not going to take this one, even though it's a 30-year-old with an aspects of 5. Okay, so get over it.
so different perspective. So I'm more spoiled than you, Andre. So I have fellows, I have interventionalists that I work with, and I want everything. I have no problem, no hesitancy in terms of saying, I mean, our fellows are here. They can attest to this, where the discussion about TPA or thrombolysis is a very quick discussion. It's, they meet it criteria, just go ahead if available, and go as fast as possible. But you're still going to go to the angio suite. And Naoki can attest to this, where I'll say, don't hem and haw about this, whether it's large core or distal or further distal. Let's treat the lesion. Let's do everything we can to help this patient. So, Andre, I would say there's no hesitancy. Now, the difference is that in this country, is that I don't have to pay for it. Now cost-wise, where I differ with you, Ashu, is that I don't have to pay for it. So, do we have the moral responsibility of having to cover the cost? No, we don't. We're spoiled. I'm, ultimately spoiled because we have everything available and we don't have to pay for it. So we can do whatever is possible. Do I believe that the lytic is actually doing something? As a core lab for a number of these studies? No, I hate to say this, but the lytic does very little. The lytic, and it's very basic, and everybody's known this for many years. Flow directs the lytic. And Andre, you know this very well. When you have a proximal occlusion, all the flow goes through the ipsilateral PCOM. It goes up through the collaterals. It does not go towards the clot. It's not directed. Targeted thrombolysis is very difficult. Injecting a drug of any kind, whether it's TNK or TPA, doesn't get to the actual clot that you're trying to target. I'm not. In what sense? I mean, it's flow determined. So it's the clot interface is very minimal in terms of what we think is the target. At the time that we think that we're treating with the thrombolytic agent, but we're still willing to do it. Now the problem is that when we compare trials to as ultimate proof in terms of we should do X or Y, things become somewhat flat, and we're okay with and I'm perfectly fine with the historical precedent of certain things were developed before others. That's fine. It's a hell of a lot easier to give TNK than it is to give TPA, than it is to do intervention. There's no question about that. So you do whatever you can up front. And if you get lucky and you have a good outcome before you hit the next stage in terms of decision management, then you stop. That's not a problem. So to me, from a spoiled perspective, we have everything available to us. We don't worry about cost. We're not held accountable to that. You use whatever you can, and that's fine. Now, it would be very different if I were held to that cost, if I had to pay for it, if I had to have an allocation in terms of number of TNKs dosing or TPA dosing I could do per month. That would be very different. And that's not, but in the United States, that's not what we deal with. And it's also very regionally where you practice, in the sense that, you know, in a rural area, it's very different than in an urban area in terms of time to treatment. And I'm spoiled from the standpoint, I know we can get on clot and we can get to the clot that wherever it is very, very quickly, you know,
Guys.
so we use what we have. I think the problem that we're dealing with is that not everybody has everything, you know, so there are differences in terms of where we practice. And one approach is not going to work the same everywhere.
Sure, they can hear us, Demetrius, but
My only
Guys,
point is
can
there ever?
can
gonna
I
be
say
room for
something?
nuance? That's my only question. Is
Hello?
it- My only question.
Yes,
is
one
there ever
moment.
room-
So, Demetrius?
Hey guys, hi. So thank you for inviting me to participate in this discussion. I do think that the maybe a way to something we should discuss is the fact that the ship, I think, has sailed. We have 2 trials starting with direct to angio. They are industry sponsors. Siemens and Philips are running this. The issue in my mind that we should probably be discussing is also monitoring patients at home and monitoring on their healthy state for signs of a stroke, to pick up that, so that activation is one thing we discussed during the conference. But how about also, and I would love to see your opinion on this, can we get to, in terms of changing policy, of having a discussion of participating on trials or accepting thrombectomy as part of a discussion that happens with patients on their healthy state, so that just like a organ donor, for example, you would have approved to be part of a trial. So one of the biggest challenges we have on these acute trials is really trying to get all the consenting and things we need to do on the short period of time we have, especially on these direct to angio cases. So I'd love to hear the opinion of everyone on are we at that level that we could discuss that type of healthy state monitoring of patients, as well as perhaps approval for participating in trials, or at least standard of care treatment in stroke.
All right, that's a great segue for the next discussion. So here's going back to the premise of no stroke left behind, right? So if you put some kind of alarm system on a patient, let's say you have an ideal thing, whether it would be some kind of watch combination, something you wear on your head, something, whatever, and you alert the system that you may be having a stroke. Take a wild guess. What's the yield of LVOs is going to be from any system like that? And let's say the system is comparable to paramedics, which would be a great thing to benchmark against. And let's say you have 100 alerts. So how many LVOs or MIVOs, let's say LVOs, MIVOs, whatever you can treat with casters, you're going to yield out of that? 30% max. So what you going to do? What
So
you gonna
Andre,
wait, what you gonna
stop
do?
there for a second.
Yeah.
There's 2 people here, part of the discussion that probably should answer this. Rado and Johan. Stroke alerts,
Stroke
fast
alerts.
AI.
So what's the yield?
So is the yield so small that's not worthwhile doing?
Well, based on like the Swiss, this old Swiss large study, we know that at least 80% of all stroke cases will have an arm, some grade of arm motor paresis. So you would, with the braces that we use and others, you would probably catch at least 80% or more of the stroke population, and then that will have the same mix as all stroke population. And really all patients benefit from being brought to the hospital earlier. Some will benefit more, but everybody will benefit to some extent. And also the LVO patients that we treat today that we're going to treat. I typically treat patients like 4, 5, 6, 7, 8 hours after their onset. If we know this, 50% of them have a good outcome, 50 don't. So if I would have had them and treated them after 2 or 3 hours, they would have a much better outcome. So we would augment the treatment that we already do today, and we would also extend that treatment to a lot larger portion of the entire stroke people. Also with the ICH, because around the corner now there are excellent, there are very exciting news about ICH treatments and how they also benefit from being found early and treated the best possible way. So I think also for the ICH patient, early detection and early triage to a comprehensive stroke center will be very beneficial. So I think we have everything to gain from this.
Yeah,
So-
and
you.
also wake up strokes too, guys. So on wake up strokes too, it's
by this logic, if you go direct, wait, so you have a screening alert, it's a stroke, we're coming to comprehensive stroke center. Spain experience told us that driving ICH 30 minutes extra, you're gonna have uncontrolled vomiting, more pneumonia and more death for that. Let's leave ICH from that for a moment. So you have stroke alert. It alerts you to any stroke. 80% have weakness. Mind you, not all of them will have large vessel occlusion. The patient arrives direct to angio with a stroke alert. Would you give TPA or would you do angio first?
I mean, no, I think there are a couple of things I don't agree with that. One thing is that the race cat, this late race cat, I mean, I guess it's true, but on the other hand, we see now that with the bundle of care, with the minimal invasive surgery, it's a whole different story with ICH, and that's just around the corner. I think a couple of years from now, it's going to make total sense to also get many of the ICH patients to the comprehensive stroke center, not to a primary stroke center. So I think that's in, yeah. But so even if you do, whether you detect a stroke, that doesn't mean that you have to triage all of them that you detect to the comprehensive stroke center. That's up to you how you organize your stroke care. So it's approximately the same. So what happens is that it's like you get the first phone call. If the paramedics find that the patient has a low score in whatever pre-hospital score you use, then they will take the patient to the primary stroke center that's closest. So you would use the same system, but the bottom line is that all patients will gain by getting detected earlier rather than later.
Agreed. There is resistance in the neurosurgical community, forgive me, to evacuation still to this day, and it's largely based on reimbursement. But there's a comment from Demetrius, and then I want to hear from Rado about this. The yield, your question, Andre, was, in terms of the yield for LVO and what you're going to do. And the fact is, it's still
let me
Andre,
make it even clearer. So my friend Tudor.
All right, your wife is complaining that we have to give other people a chance to talk.
So my friend Tudor put a catheter angio in the emergency room for exactly that, direct to angio. And I love Tudor for doing this. This is a pioneering work. But would you rather give IV TPA for non-occlusive, non-large vessel occlusive stroke and not take the patient for angio, or take the patient for an angio, do a normal angio, and then what you're going to do? You're not having a stroke. That's what you're going to say to the patient.
Right.
The patient is disabled from
Right.
a small occlusion that you don't see. That
Andre,
is the core of the argument.
But
here.
Andre, all right, timeout. Even your wife is saying timeout. You're violating the rules of a Jeffersonian debate. The purpose of a Jeffersonian debate is to hear from colleagues and to hear differential responses, different viewpoints, and then to summarize. So why don't we do this? Demetrius, why don't you comment, because you wanted to speak, and then Rado, you lay your cards down, and then let's come around.
Thank you. So I think that one of the most impressive pre-hospital monitoring that we're doing are really during the sleep of patients that are to detect change in neurological exam during the wake up strokes type of thing. I think that's really something we could make a difference. But on the comments regarding neurosurgery willingness to do ICH, and I think that's changing, and you will see much more trend towards acute same management as acute stroke for ICH. It will take some time, but I think it's going in that direction. And I think regarding the issue of trying to get we give TNK to our patients that are going to thrombectomy, and if it's going to be done before or after the TK3 is obtained, I think that is what we're going through definition right now. But it doesn't, just because you go direct to angio doesn't mean that you're not going to give thrombolytic. And I mean, TPA takes a little too long to good. That's one advantage of TNK, but I think that that discussion, I don't think it's a big debate if that's going to be defined as the trials come. But there is a role for be able to actually use both, still going direct to angio.
I'm just been listening to this discussion, and amazing. I mean, all the thoughts that were laid out are very clear to all of us. But coming back to the question about early detection in a disease that is time sensitive, rapidly reversible if caught early, and it's somewhat obscure to many people, the question of early detection is there's no question. I think it's pretty obvious. So we have to solve that first problem: early detection, early triage. And I can't make it more simple. And I have Dr. Gross next to me. It's like, I mean, I want to pass it on to him to talk about it, but really, we know what to do with the cerebrovascular disease. We know how to treat it. We know where to take the patients. Is how do we actually simplify the process, and whether it's automation and that's what we're working on, right? We want to automate it because maybe the human mind it's too sophisticated. Maybe AI needs to take over and tell us what to do, or I don't know. But I'll open up to discussion.
Mary.
Yeah. Yeah. So I'm interested on adding on the TPA versus, like Ashu says, directly going to angio and whatnot. I think in the ideal world, I think we know when somebody has LVO, sometimes even without CT angio, we all understand when it comes, with the big case deviation, aphasia and all that stuff. And we know that's LVO. That's not small vessel. And I think it would be perfectly fine if they came quickly to just go. But at the same time, also like David says, we don't have any shortage of supply, and we're not anybody is not like holding us and making us pay. So we don't want to go into the discomfort of avoiding or not giving. So we have just the luxury. So we just give it, and and then go to thrombectomy.
So I agree, but the step that we're skipping over is we're assuming the diagnosis. We know the diagnosis is an acute neurological deficit of significant, degree. Somebody is acutely impaired by a certain amount on an NIH score, and we know it's either acute ischemic or hemorrhagic stroke. But we have two different pathways still at this moment in terms of what we do about it. And, the current status in 2023 is that for acute ischemic stroke, I think the majority of the world will be willing to give a lytic if within a time window, and whether you believe in it or not. and you think it's actually going to do anything or not, I think the vast majority of people are willing to do that. Doesn't matter which lytic, and then move to the next stage. So I was saying earlier, our staff know very well. There's very little thought in terms of getting a lytic. You just do it and move on. But you start going to the cath lab, you start going to the angio suite. Hemorrhage is very different. So, our staff hears this all the time. There's this euphemistic term of a stability scan. And, I hate to say this, but the imperative, is that neurosurgery as a field has to change, has to evolve. So I still remember the days where many of you know, where I hate to say this, and Demetrius, you can defend this, but neurosurgery had no interest in acute ischemic stroke. Now, to a certain degree, there's not much that the neurologist and neurocritical care folks can do something about, but the vascular neurologists can't do much. And now the imperative is on, the burden is on the neurosurgeons again. This idea of a stability scan, doing a CT scan to assure stability is not just euphemistic, it's ridiculous, right? There is no stability because the hemorrhages expand. Jim, you can talk about this in terms of fastest. We know that they expand early. So what you're looking for is is a fait accompli. You're waiting for the lesion to evolve to become stable. And that's not a stability scan. You're not achieving stability by getting a scan 6 hours later and then deciding to go to the OR. You are intentionally waiting till the hemorrhage evolves, and your expectations are a little bit different, and you say, all right, now this is the patient, they're devastated. Yeah. Now what am I going to do? Yeah. So I think, the imperative, I hate to say this, is more on the neurosurgeons than it is on, anybody else. It's also on neurocritical care that it's time to jump on this from a hemorrhagic standpoint. I would actually argue that from an acute ischemic stroke standpoint, we know what we're doing. Yeah. So, it's time to bring hemorrhage up to speed.
Yeah, same thing. Even for ischemic, they wait, for hemicraniectomy. Call me, wait for me. There are some people who make you wait a lot. Yeah. But I'm not talking about hemorrhage. I'm talking about ischemic stroke. And if resource was not if resource was an issue, I think Ashu's idea of going directly to thrombectomy would make sense.
So are we talking about hemorrhage or are we going back to thrombectomy?
We're talking about clinical criteria. There's a severe deficit neurologically. Yeah. We don't know whether it's ischemic or hemorrhagic. So let's start from that point. So we have to include hemorrhage.
Yeah.
We can't just ignore it.
So let's think about the patient comes to the ER. Patient comes to the ER. It's a code stroke. We rush the patient to the CT scanner, right? We examine the patient, get a rudimentary history, rush the patient to the CT scanner to check right away, is it a hemorrhage or is it an ischemic stroke? Let's go the ischemic stroke route, okay? All right, it's a big stroke. We've got a CT that shows no blood. Get the TNK started, call the endovascular team. The endovascular team gets down there right away, which sometimes they do, and they're ready to take the patient right up to the endovascular suite before I can get the TNK mixed up and given to the patient. They're going right up to the endovascular suite. But if they can't, we give the TNK, right? And then they go up to the endovascular suite. It's just a sequence like that. And I don't think anybody ever really stops to think about, well, now, if the patient's got a relative contraindication, they're pregnant or they're, got liver disease or some other relative contraindication that may say, well, maybe, the patient's going to go up to endovascular and there's a relative contraindication to giving TPA. Maybe I'll withhold TPA in this patient. And I would add, if they're at the end of the TPA time window, they're 4 hours out and my endovascular team is ready to take them, I'm going to be less urgently interested in giving them a thrombolytic than if they're in the first hour. They're in that first hour, so I'm going to give them TPA no matter whether my endovascular guy is ready to take them up there or not. So I just think it's all logical clinical decision making in these cases. And I think every patient is different and you weigh all the pros and cons. So that's the way I look at it with ischemic stroke. With hemorrhage, the early studies of early intervention in surgery and microsurgery, the Japanese went in and they evacuated the hematoma early, and they actually had good results in a small series, but they did micro dissection and actually cauterized the actual bleeders in the bleeding bed. We did a study, we tried to recreate that where patients came in with a hemorrhage before a stability scan. We called the neurosurgeon just like we call the interventionist now. Come on down, let's get this clot evacuated. And they did it. They evacuated the hemorrhage, and most of the time the blood reaccumulated when they did that because they didn't go in and actually do the micro dissection needed to cauterize the bleeders. And so I think that's where the stability scan has come in with regards to now doing stereotactic surgery in these patients. I think that they can't stereotactically identify most of the time when the patient's still bleeding, so they want to get and do the surgery after the bleeding has stopped. So I think
may I
you know,
comment
talk
on
to
that?
the surgeons, and they're on the line, but
I
as to
ca-
what they think about
Oh,
operating.
is that so, Demetrius or
I
Shai,
don't-
or
we have-
anybody want to talk about is it true from a neurosurgical standpoint?
We just got invited to be part. Actually, Marius is running a trial of doing early actually an angiogram and possible embolization of that feeding that spot sign or the area that's bleeding prior to going to the OR, which is really interesting because we was not a practice that we were doing. We certainly, if you do a selective angiogram, you have a much higher yield on identifying the spot where the bleeding is coming from, which is really maybe a better approach to do some of these deep hemorrhages. The dissection may also cause some trouble. So the advantage we have in ICH now, evacuation is for minimally invasive procedures of removing the hematoma, but to eliminate the source of bleeding, we would have to find a minimally invasive way to do that too. And I think maybe the selective angiogram with the embolization may be a good way to go. So that's where this is going now, and I think more to come on that.
Demetrius, do you think you can see the bleeding vessels?
Yes, I've seen a few cases that he showed that was very convincing, actually.
So I'll tell you my protocol. I've been using Nico port evacuation tubes since 2015. That's when they first came out by the Nico Corporation. What that allows you to do, and I used before the Nico port evacuation system came out, what we call Artemis today was called Apollo before.
Yeah.
Apollo by penumbra was used as an intraventricular hemorrhage evacuation device, not an intraparenchymal. They rebranded themselves after they saw the trend of the retrospective series from Nico demonstrating a benefit with evacuation. With exoscopic evacuation, you can get both a sucker and a bipolar cautery down there and completely evacuate and cauterize the offending. I have never, and I have personally done, I actually was asked to look at my own series. I've done 50 port evacuations since I started as an attending. Not one has recurred. When I do the I do them as soon as if the patient's big and symptomatic, I go when my neurocritical
Spot sign present or not?
If a spot sign is present, I only need one thing. I need a CT angiogram to make me see that I'm not about to fight an AVM through a port. If I'm going to fight an AVM, that's a very different scenario because then I take them to my hybrid OR, I embolize them, and then I take them out right away.
No stability scan.
I don't need a stability scan because if I wait, the patient will be dead. So that's why I just do it right away.
That's great. That's great. I mean,
But I'm not alone. I don't think I'm alone. Look, I'm early mid-career. I've been doing this for 9 years, right? The people who don't get it are the people who are 25 years out because it's subarachnoid hemorrhage. That's what they make it akin to, that you could wait in the morning. And there's very reasonable data coming out of Emory that shows with an aneurysmal subarachnoid hemorrhage that it's better to wait the next day until you have all hands on deck, right? With that being said, intraparenchymal hemorrhage is a very different beast. It's as different in bleed as ischemic stroke is when you have an LVO versus a lacunar infarct.
But again, having what Demetrius is saying, having actually identifying where the extravasation is coming from and embolizing it as a paradigm or as a shift in treatment, pre-surgical embolization. What do you think about that? Because I think this is this is interesting because none of
It's
us,
super
because we do
So here's my
CTAs,
issue.
we do CTAs, we see the spot sign, but rarely we do
I'm a
catheter angiography to see actually the
Yeah, so I'm a dual trained.
side.
I'm
So
dual
what
trained, right?
would
I
you
do
do that?
open vascular and endovascular. So I have a hybrid OR. So I have the perfect setup to do what you're describing. All my work is done as a hybrid OR.
Would you do it?
As a surgeon, I'm already getting there to take the clot out. As soon as you decompress the blood, you see the offending vessel and you cauterize it. It goes very quickly. And as someone who has to take care of ruptured AVMs, finding and cauterizing a spot sign is a whole lot easier than managing a ruptured aneurysm or an AVM open. It's the easiest thing in the world to do. You evacuate, it decompresses, it bleeds, you cauterize, you're done. It's not rocket science, I promise. It's just brain surgery.
But that's only you doing it, right?
No, it's all
Well,
like it's my whole group.
guys,
Would you standardize it across all surgeons? Would you like do endovascular? Because-
Demetrius,
Go ahead.
why don't you speak up before I have to give Andre the microphone?
Okay, thank you. No, I think the other thing that we should consider here is that
Demetrius, go ahead.
there is a time to reverse anticoagulation. So especially with Andexa and other things coming up, I think that the angio could be done while you're getting the patient ready to go. You know, if there are things you need to correct before blood pressure control, different things. So I think that it's still on being evaluated. I don't know if this is. I totally agree that if you can open and remove the hematoma and find the bleeding source, it's a great way to do it too. I'm just sharing that this could be another pathway in cases that you may have to delay the OR.
So it was music to my ears to hear everything you said, particularly 6 hours. But in an enriched trial, from the initial evaluation to when they deployed the device, was the magic 6 hours.
And the interesting thing about that, the enrichment, and I don't know what the final protocol is because the paper hasn't come out yet, so I can't read all the amendments to the protocol. But you know, the original trial was you randomized and then you had to go to surgery within 24 hours. That was the initial protocol. Now, I don't know if that's what happened.
Well,
because
they
I know
were encouraging within 8 hours.
Yeah.
Is what I understand, but their median ended up being a little higher.
Yeah, and I went right away. So we were in the enriched trial and I just went right away just because, you know, we wanted to, you know, you're treating the patient, you randomize and you just went. That's what we did.
Are you talking about the study that, you know, the Kellner's, that study? Not Jacob. I'm pretty sure they get a stability scan before they, and I'm not saying that's the way to go. I
Yeah.
hear what you're saying.
Yeah.
But my recollection is they get the stability scan, make sure there's no continuing ongoing enlargement.
So
before they go.
and that's the difference. And the only thing I know about Kellner studies, it's an endoscopic approach to evacuation where you're literally sitting this Artemis thing
Right.
and you don't have the same, and you're just
That's what I'm
sucking.
saying.
You don't have the same control to have bipolar cautery. I mean, it's
That's-
surgery, right? And these surgical tools really work well as long as you have access to them. I think what they have with the endoscopic port is you have this single, it's almost a monopolar with a foot process that you kind of buzz around and you hope, and what that's actually a disaster from a surgical principles, because what you do is you encourage the vessel, the offending vessel, to retract when you burn the top of it, whereas if you have a bipolar cautery, which is the standard way to take care of a blood vessel, you pinch in between and you cauterize the vessel.
Well, it may be a disaster, but they're doing a trial. So my question is, your approach, which makes perfect sense, has that been tested in a study?
So that's the enriched trial, Jim, that just got, and for those of you who don't know, because I ended up, as soon as I got the phone call, I went from the AANS in April to the AAN on Sunday. Like I flew from LA to Boston to present the enriched trial data to neurology. And what that showed is in patients who present, it was all hemorrhages. It included both basal ganglia hemorrhages as well as lobar hemorrhages, that evacuation randomized and preferably within 8 hours, that the patients not only had a survival benefit, but they had a shift in their modified Rankin scale at 90 days.
But they did get enriched, literally. They dropped the basal ganglia group, right?
They did, but even when they included the basal ganglia hemorrhage back, so they did a trial amendment partway through to only randomize basal ganglia, to only do lobar hemorrhages, but they actually did the analysis and reported the analysis that included both the basal ganglia hemorrhages and the lobar hemorrhages, and it was still statistically significant. So when you parse it out, The lobar hemorrhages were even more statistically significant by themselves, but when including the basal ganglia hemorrhages, it still remained. And what I really like about a basal ganglia hemorrhage evacuation is often with the way a basal ganglia hemorrhage works, you go down the long axis, right? It doesn't sound intuitive, but you follow the long axis of the basal ganglia hemorrhage, and these tubes are really long. And so you can track straight through them. And what my neurocritical care colleagues can finally do when I get rid of this for them is that they don't equivocate about extubating the patient. And I evacuate and I make them a deal. I was like, look, I will go in the middle of the night and take this clot out, but you have to evacuate. You have to extubate them within 8 hours, right?
I just want to say, I've been waiting decades to hear a neurosurgeon say what I like about a basal ganglia hematoma evacuation.
Well,
Guys.
and also, correct me if I'm wrong, but also the part of the technique is that you can irrigate and visualize. This is something with minimal invasiveness. And so you can finally see that bleeder and you can go approach and cauterize it the best.
And the really cool thing, Andre, is when you take your exoscope out, you can actually look down, whether you have your surgical loops on or a microscope, you can look down that long axis and you can see your evacuation region. And you can even do a quick look with the same, because it's you've created a potential space has now been removed, and the brain doesn't take up that space immediately, right? So you can look down there, you can check, you can double check, and I actually have enough time and can see clearly enough that on my way out, I line my area with Surgicel before I close up.
Yeah, I think,
So
guys,
we
one
have
important thing we
have
have
a
this.
happy neurosurgeon.
Oh,
We have a happy
so I just wanna-
neurosurgeon, and the patient doesn't benefit from that.
Wait, Demetrius, wait a second. Let Peter talk about this from a neurocritical care standpoint, and then Demetrius, you speak, and then please, let's move back to ischemia.
I think it's wonderful from a neurocritical care physician's point of view that the neurosurgeon is happy, and I'm happy when my neurosurgeon is happy, but the patient is the patient happy because if you tell the patient, listen, son, I could see everything in such a great view down the channel. I saw where I had to irrigate, and that was just a wonderful view. And I had the picture that you never will see because you are the patient. And at the end, with the basal ganglia hemorrhage, you end up the same as if I, as a neurosurgeon, hadn't seen that wonderful picture. Is that the target that we want to achieve? I mean, I was glad when I heard the enrich results in terms of non-deep hemorrhages, and that there finally a door is thrust open. But the deep ones, I still believe you shouldn't go there.
But there's a reason. I mean, it enriched because they weren't showing an effect, and the subgroup analysis was really clear. I don't think there's a debate. We're not taking the basal ganglia, we're taking the cortical ones, right? Is anyone debating this?
Well,
Demetrius,
if you have basal ganglia spare,
wait,
it may be worthwhile.
Let Demetrius speak, Andre.
I believe Bruce wants to speak. I'll let him
Oh,
go.
Okay.
Thanks, Demetrius. I just wanted to say, I mean, in enriched, what is that, 80 patients, 40 in each arm for the basal ganglia? They stopped it because it didn't have enough signal, but I don't think it's evidence that it doesn't work, or at least that some other technique that might do a little less damage would work. So in our Australian trial, we're still very much randomizing patients with deep hemorrhages using a surgiscope, which is slightly smaller, but does have bipolar cautery, and you get a great view, as Shai said. But I think that's still an open question. I wouldn't close the door on the basal gang.
So my comment was, if basal, not every deep hemorrhage is the same. If internal capsule is preserved, it's worth fighting.
I just wanted to kind of shift topics here back to one of Demetrius's points about consent. I think one of the big barriers we have for randomization in the US is this issue of getting patient consent. And I was kind of interested in getting Pooja and Jim's kind of take on this, whether we would get to ever a stage where we can get community consensus for exemption from informed consent? Is there a strategy nationwide that, for example, Canada has taken this approach? And I think that is one of the big bottlenecks for whether it's a hemorrhagic trial or ischemic trial or whatever the trial, like acute ischemic stroke by nature is limiting. And I think this could open the doorway for traumatic brain injury, for all kinds of neurological emergency type of trials. And is there a strategy we should be thinking about through StrokeNet or through other mechanism where we just do this nationwide, put this to rest, and so we can move on and start enrolling in all these trials? And
I mean, it's a great question. So I mean, Jim can probably speak to the fastest part better, but I'll just say that it's really clear in other countries that emergency consent is much more feasible. And we saw how much faster startup was and fastest in non-US countries. I think the thing that gives me hope is there's actually going to be a formal meeting in December with FDA, and it's going to include NIH leadership, Siren leadership, and StrokeNet leadership to talk about the whole EFIC situation and how we can do better. So I haven't seen details about the program, but at least I know that's happening. So hopefully there'll be some progress and some discussion.
Just one question I had is it sort of state specific, or could it be done nationally, or does it have to be
As
locally?
far as I know, this is all national. And I think what's also really frustrating is, the FDA guidance isn't that specific. So every IRB is interpreting it differently. So like Jeff Saver brought it to our attention that like our central IRB for fastest with Advara was making us go through way more hoops than he had to go through with Western IRB. So we ended up like negotiating with Advara and saying, hey, like Western, let makes it easier. So I just feel like there's an opportunity here to simplify things. And that's certainly the push I'm going to try to make at that meeting, and we'll see.
Along those lines, I mean, this has been brought up many times in the last 2 days, but if you do, as everybody knows here in this country, if you do anything that's NIH funded, you have to have reliance on a central IRB. That's a requirement from NIH.
It's true, David,
but Andre, let me finish.
Western, I'm a recipient on the other end.
No, I know,
You
but
still need to
let me
get
just
local
finish thought for a
IRB
second.
and maybe
I've been there before many times. Then when you go to the local IRB says, no, we have the right, to cast our own judgment, and that can't happen.
No,
And it just, so it's not uniform. So the local IRBs must conform. I mean, there's a very simple way of doing this. The very simple rule should be, if your local IRB cannot conform to NIH requirements, it's a mandatory requirement, then that institution cannot participate in NIH funded, federally funded studies.
That's really well said. And in fact, that's what NIH intends. So the current funding announcement for StrokeNet required that when sites entered StrokeNet, they had to commit to the central IRB process, and NIH plans to enforce that. So there's actually, you're going to see a difference now, like the local IRBs, if they're pushing back and they won't play, the plan is to actually let go of those sites.
Right, but so you brought up another point, Pooja, which is there's central IRB A and central IRB B. So why is there a difference? If there's central IRB, there should.
Wait. This is Jeffersonian dinner. We're in the United States of America. Your president can issue an order that there may be a federal law and a local judge can ban it. So I'm sorry, I've been through a lot of IRB applications when we had Western IRB approval, we had a funded NIH grant, and the local IRB acted out, and nothing you can do about it.
But I'm going to say that what I'm hearing from our NIH colleagues is you're not going to be able to play in StrokeNet if your local IRB won't listen. And we're going to push this a lot harder because it's now written into the funding applications.
Thank you. And what happens with now IRBs want to participate in funding applications so they can kill it before we can even reach the StrokeNet.
I mean, I think hopefully with just more education, this will go away. That's all there is to it. I mean, there's literally federal regulations. This is just local IRBs catching up with what our federal, policies and regulations about how this should work.
Well, so there's a dilemma because, when it comes to ethic, you need community participation, you need, nobody has a higher moral ground, so to speak. So what makes one IRB think that they know better than the next? It doesn't make any sense. It should be, an even playing field. So I agree. And the simple fact from a business standpoint is that, if you can't participate, you can't receive NIH funds.
And self-governance wins still. So this is the society.
I think this is a good thing. Does anyone want to argue that we shouldn't make this easier?
It comes to ridiculous points because people overinterpret protection of human subjects in lieu of their view of your science. I mean, I had the most ridiculous examples of local IRB rulings on NIH-funded trials in my life, so that it's not even worth spending time here. But I'm glad that if NIH wants to reinforce it and modify their behavior through contracts, I think at least big institutions that rely on these contracts are going to yield. And finally, we should not be spending time convincing ethics people on federal, state, and local level altogether. So that's just ridiculous.
So we have a few minutes. I don't want to drag this out too long, but let's switch topics.
I thought we were going like.
No, I mean, everybody's going to get tired at a certain point. So, so I did want to switch subjects for a second, Andre. I'll take prerogative that we've talked a lot in the last day and a half, 2 days about different approaches therapeutically, diagnostically in terms of ischemic and recently hemorrhagic stroke based on deficits. How do we make the system much more efficient? I said earlier that, that there's always time for science, on the academic side. We can spend another decade, 2 decades doing more trials. We can keep on doing this and, wringing our hands when we get more negative trials. That's not how industry works. All right. Because if you do that, there's one company after another that's going to fold. They can't work that way. And we should be, we shouldn't work in an idealistic system where we are focused only on the science, but we don't have to pay for it. At the other extreme, the business world of it on the industry side is you have to make certain products come to market or be developed a little bit faster. How do we make the systems a little bit more efficient in terms of trialing various therapies? So Pranitha, I don't know if you want to speak to this, but you have a company now that you're a co-founder of that hopes to demonstrate that we can get to these answers faster. And what I was mentioning when you were giving your presentation earlier this evening was, all right, what's it going to take? What are you going to prove to industry that your approach is going to work? Because otherwise they're not going to pay for that information. Otherwise it's not worthwhile. So what's your market strategy in terms of that information and how are you going to prove that it's going to accelerate things?
Yeah, I think the first thing we need to gain is the trust of clinicians that this technology actually works in answering the questions that you have in, I don't know, deciding a certain population that would benefit from a treatment. And I think the way we want to do it is if we can predict one of the trials in parallel as they're happening, that this is what is going to happen and we get similar results, that's a way to gain trust. That being said, we're also working together with Gravity, for example, to see how we can optimize their stent design. And if we can do that, then we also gain trust of regulatory bodies. So I think they run in parallel, and that's how we want to get it. But the end goal is to have this technology improve devices and in future also use them for pharmacokinetics.
For both, for any strategy, diagnostic as well as therapeutic, whether drug or device, if you go to FDA and you say you're learning, that's a no-no. So you have to have a set protocol, a priori. You cannot modify that protocol. You cannot learn. And I've seen this again and again. If you tell FDA that during the course of a trial you're learning, you're doing machine learning, you're doing any type of AI, and your model is changing, they'll say, freeze the model, and then come back and do another study. You cannot learn along the way. So come to us with a intellectual product, a model that's frozen. At that point, a protocol, an algorithm, and freeze it and test whether that works or not. So the challenge that your company has now is that you have to have that set model, and it may or may not work. So it's a big risk in terms of the model may be wrong. You can't play both sides of the fence in terms of adapting along the way.
There's two sides to it. FDA also recommends that 1 in 7 clinical trials be supported or replaced in a way with in silico trials, because it's just a way to save money and resources. And that's also where we aim to facilitate trialists and also just device developers. That's one side to it. And the other side is, if you develop any kind of software or technology, there's always one model that you have to freeze that goes into CE marking. And that's the same with in silico models. If we have an in silico model for device A, then we have to freeze it before we allow it to go into any FDA approval for regulatory things, right? So it's the same with any technology.
I mean, I think that, I think that part of the issue is it's the same theme whether we're talking about StrokeNet or we're talking about, doing clinical trials or innovation. It's just become crazy expensive in the US to do normal things that the rest of the world can continue to move on forward with. And I think device development's a good example because, if you, for example, in the case of a new stroke device, have a prototype, making that prototype, testing the flow model, getting it to the point where it goes to an animal model, then design freeze. Each step is crazy expensive. I mean, GLP animal testing in the US is twice the price it is in Israel. And even Israel is still very pricey, but it's still cheaper than the US. Every one of these steps adds up. And so then in the end, whatever product you produce, whether it's a drug or device, companies sell at these crazy prices to recoup all that R&D that they invested into it. This is a problem we have categorically, whether it's in the private sector or even in just the clinical trial sector. And I mean, I think the only solution that's short term is to move outside the US. And then you can have these sort of surrogates, with the in silico models. What we can do is basically say, okay, before we even go to a new prototype, try it out in the in silico model that maybe shaves off a few prototype designs that you don't have to then make and then go into flow model. You can hopefully skip a few of those steps. Otherwise, the stroke device that you end up making ends up being crazy expensive, and then it just doesn't become practical to sell outside of the developed world. So I think we're going round and round in circles because of how crazy pricing has become, whether it's CROs or whether it's, simple things like IRB fees. All of these things are just making research very untenable in the US.
I think all of that, I completely agree with you, and I agree with everything that's been said, really. And I'm just wondering, so this is a bit of a philosophical point, really. So we've looked at presenters, and this has been raised before. So we've got presenters to hospital, 50 to 55% in New Zealand present out of the window, out of the time frame that we currently have, where we have proven efficacy. And we're looking at the therapies to improve the benefit we're already seeing by incremental amounts. And we've talked about devices that detect stroke early, and all of those things are really important. But I just wonder, I mean, are we really convinced that the people who are experiencing a stroke, who are awake at the time that they're experiencing a stroke, know that they're experiencing a stroke? And this isn't fancy, and this isn't attractive to industry, but what about simple education campaigns to just spread the word about stroke symptoms, to try to educate the public across the globe? This isn't making money, and maybe America isn't the place to do this because it's driven by industry, but maybe there are countries where the health benefit from treating early is enough of an incentive to reduce cost of rest homes and hospital level care to do this. And I really feel a bit sad sometimes about, I mean, I used to work in America, and it's, like the incentives you have here, I just, listening to this, I feel like we're skewed a little bit towards working industry and investment. What can we do together to drive awareness? And it sounds so simple and unexciting, but what can we do more about that, those 50%?
Value-based care. Value-based care is value-based care is a concept that existed in U.S. health economy, and I'm sorry, I'm not an expert on this, but this is where it is. Early treatment, faster treatment, rewarding system to hospitals, to physicians. I think that's the future. And it exists already, but not specific to stroke, unfortunately. But this is where we have to advocate.
Education for stroke has always been a primary goal and an enigma. And the reason it was an enigma, because you run an intervention, no matter how good it is, and the attention span of public just goes down. It just doesn't matter. Even if it's a war, even if it's a risk of a third world war, it just comes down after a 2-week splash. Sad to say that. So we're not any different, but the world is changing, and information technology, you can intervene on kids and grandkids and using digital world, because the family members who are at risk, they're going to be checked on by the family. And so families are more and more relying on smartphones and such, and getting the word out and making sure that they are able to alert to a problem in a remote village or whatever. That might be the ticket to the future. But back to Ashu's point, I hear you. I'm in the same boat. I'm an inventor. I'm trying to bring devices in. I firmly believe that if you invented a thing in a country, you should not leave the country to test it for greener pastures or cheaper grounds. You should be able to do it in your hometown, ideally in your home institution. That's my commitment to research. Why? Okay, so I will challenge you to think, if you're inventing a device, what precludes you working with her across the borders, across the state, run this thing, even in theory, get her on board, run it through the startup company here in United States with her expertise brought in, mapping out the best possible way. And I can tell the CROs get stroke specific CROs. You don't need to pay for these expensive guys who advertise. They don't know nothing about stroke. The expensive guys know nothing about stroke. There is niche specific CROs that will work with you and make the trial much cheaper, but we can take it offline.
Just as final comments, because we're getting told that even here locally, it's getting quite kind of late. Just in final comments, just 2 or 3 comments that are summary points, action items at the end of any meeting. Is there something productive that we've formulated through this discussion? We need to be more efficient, I would argue. Andre, you have taken issue with certain apparatus within clinical trials to make it more efficient. There are people, there's, needless to say, that there's good businesses in doing clinical trials, and just doing one negative clinical trial after another. That's not what we're focused on. It should not be what we're focused on. So a couple of people make a couple of final comments in terms of productive points, not negative or nihilistic points.
I'm sorry to shift gears so late, but another thing that I think we haven't mentioned so much is the fact that we rely on imaging for our diagnosis, and that's good, of course, but imaging is constantly changing.
I agree with that.
So, and there is a risk when the CT scanners, not just by using, like Raul mentioned, that we get restrictive by using advanced imaging, but we also risk to be restrictive by using just better CTs. We experience that a lot from our hospitals, that with better scanners, that suddenly they see early ischemic changes better, and then that gets restricted for the patient, so the patient is not brought to our attention, for example. So I think that, and now the coming new scanners all the time. Now we have the dual energy scanners that we use. We got the photon counting scanners now. So it's happening really, really fast, and we base it on the old aspect paradigm that's done on really, really old scanners. So I think that's an area where sort of like core lab has an important role to sort of set an even standard and get that out, so that we can say, okay, so this is what's relevant for like a 70 kV image from an Philips scanner, and this is Siemens photon counting 80 kV, such like that.
Two other comments. Productive.
So I know you were talking about whether we should give TPA before thrombectomy. Actually, at my residency, we didn't give TPA before thrombectomy for LVO. We usually didn't. I know that's like the exception. At Stony Brook, we did not. Most of the time. No, actually, our outcomes were pretty good because the operator was very good. I mean, he got TK3 most of the time, and the patients did very well. And I felt confident not giving TNK or TPA in those patients. But if the operator was not good, I wouldn't have done that. I would have given TPA 100%. So I think, yeah, and that's the majority. And I think that's the issue. It's very operator specific. And then the other thing I just want to say in terms of education, I do think education is really important, and we don't focus on that as in the stroke community, because I think we're not very good at spreading the word, because we don't make it sexy. Like we're not marketing, and we have to use marketing techniques to get like a larger audience. I mean, I talked to my mom, who's not very educated, is a housewife. Her friends don't know what the signs of a stroke is, and it's an affluent community. I mean, it's just not sexy, and we don't know how to get to that audience. And I think we have to learn how to make this message more sexy, more accessible, right? And there are ways of doing that. I think there are ways of doing that. We're not focusing on that. And I think it doesn't take that much money. It doesn't. And I think we could help a lot of patients come to the hospital a lot earlier if they understood in simple terms, in a simple message, what stroke symptoms are.
So
Great statement.
So your suggestion is that stroke should be sexy. Okay. One last comment. Productive. I mean, that is very euphemistic. I don't know if we can achieve that though. So
I mean, so I ran a fashion company, so I have some marketing experience. I think we can do it. It's just that, unfortunately, medicine is just a group of people who have spent so much time studying and not interacting with people, not going out, not getting a drink with someone from a different industry, that they've lost touch of how to, like, we're sitting in a room of people who are in the same subspecialty. I mean, we're not interacting with like people in finance. We're not interacting with people in government. We're all sitting, talking amongst ourselves about things that we all are interested in. And that's the issue. Like, we have to talk to other people to figure out how to get to them.
All right. I'm gonna give you a great suggestion. So we did a study that every time a celebrity has a stroke, there is a spike in Google search, absolute spike in Google search. We already traced that. So with your background, I can connect you with my guys who work with Google. Let's map something seriously out.
I was just going to share on that note, since we, started to have some comments about awareness. Something I learned recently that I was kind of excited about is that AHA is doing like a formal study to see if the be fast message can be remembered as well as the fast message. And if it could, then that could become a national and international campaign. I know some people have adopted be fast, but we don't actually know if people can remember be fast as well as they can remember fast. So I just wanted to share that. And then Rapido has actually been very well studied in Spanish. So that's another positive step in stroke awareness.
One last comment. I don't know if you heard, but Rado is saying you don't have to memorize these things. AI is going to figure it out. The automation is going to figure it out. Yeah. Let your cell phone do it for you. So why don't we end there? Thank you, everybody, for participating in a very productive discussion. And needless to say, we'll see you early in the morning.
9 o'clock, right? Not early.
David, I am not the first speaker tomorrow, right?
It's much later.